All right, it's time for us to do our Kegel exercises. Why do we do them? Who cares? Well, the reason is that our pelvic floors are very important for our health. Our pelvic floors hold up the organs of the pelvis, including in women, the uterus, the vagina, the bladder, and the rectum. And so the stronger you can make your pelvic floor muscles, the better you can support them.
I like it. So then we have this patented GynoCast, customized Kegel exercise. World-renowned. Custom.
And acclaimed. Prized-winning.
We sound super fancy when we talk about it like that.
That's right.
But you've come up with this great routine that we can use to help strengthen our pelvic floor.
So easy.
Right. So you ready to start it off?
I'm ready.
Okay. 3
times a day.
6
days a week.
9
seconds per Kegel exercise.
And 12.
Kegel exercise in a row for a rep. And so you're just doing it 3 times a day. Do 12. Hold it for 9 seconds. Okay, you can do it 6 days a week and take a day off. You'll have a pelvic floor like a chain link fence, Twila Dang.
I like
You'll
it.
be able to pull a trailer. You will be the envy of your neighborhood. You will walk taller.
I'm going to go do them right now. I'd like to walk taller today. So make sure that you're doing them, and feel free to go get that infographic off of the GynoCast Facebook page and share it with your friends as well. Stay tuned.
Hello, everyone. My name is Dr. Eric Heegaard, and you are listening to the GynoCast. I'm here with my buddy, my boss, Twila Dang.
Hi.
So
How
nice
are you?
to see you again.
You too.
So we are talking about a very important subject today, something that I think we need to talk about more, which is sexuality and aging. Because I think that in the media, sometimes everything that's swirling around us makes us think that sex is just for people who are 25.
It's not even for 25 anymore. Now
Yeah,
they treat that like it's old now.
Yeah, you're right. You're already on the waning side of sexuality. Yeah. But in fact, good, healthy people can have sexual lives way into their older age. And so we're going to talk about this, and we have a very special guest today, Dr. June LaValleur from Minnesota Personalized Medicine. She is an expert in sexual health, and I love this as well, complex menopause and soulful aging. Dr. LaValleur, I love that idea of soulful aging. It's a beautiful phraseology.
Yes.
So thank you so much for joining us.
You're so welcome. I am really so happy to be here. You know, Greg, or Eric, I do this all the time. Yeah. You have a relative.
Well, you know what? We should give the backstory, because it's a delightful backstory.
Yeah, so let me just say that I've known Dr. LaValleur for a long time, and she knew me when I was just a baby gynecologist, just like a little fluffy chick out of my little gynecology egg. And so Dr. LaValleur was staff physician at the University of Minnesota. She was the staff, we call them our attending physicians. She retired as a professor of obstetrics and gynecology at the University of Minnesota. And that's, Twila, a big deal.
Indeed.
And you were also and are still known nationally for your work with menopause. And I think aging and health has been something that's been very interesting and an interest of yours for many years.
Right. Well, it probably started because I started medical school when I was 41. And when I did my residency, it was very obvious to me that nobody was paying any attention to aging and sexuality. And so I was 45 when I did my residency. And when you're 45, you're perimenopausal. And the last thing that you want to do is, upset a perimenopausal woman, okay? So I had planned to go back to Alexandria, where, incidentally, Eric's father did my C-section.
It's a very small world.
Isn't it? It's a small world. But when I discovered that we just were not teaching residents about sexuality or menopause, I approached our chair and told them he was doing a blank job and needed to do a better job because there were 40 million menopausal women out there. And so he offered me a job, and I thought, I can either change things one patient at a time, or I can change things by teaching medical students and residents and affect thousands.
That's
and
right.
So that's why I joined the faculty.
Well, and again, I think you were really in some ways on the forefront of this area of women's health, and that's something you should feel very proud of, I think.
Oh, thank you. Thank you.
Well, so I'd like to talk a little bit about kind of the definition of sexuality, and because I think people think of sex and the biomechanical aspect of heterosexual or homosexual sex or whatever, versus being a sexual being, because I think, and I'd like to hear your feelings on this, that you could conceivably go through your whole life never having had sex, but still be a sexual being.
Absolutely. I mean, we have ultrasounds of fetuses in utero, male fetuses playing with their penis. We are
June,
sexual
this is a family show.
beings. We are sexual
Are you serious?
beings. Yes, I'm serious.
I don't. That says something. I'm not sure
Yeah.
what.
I'm not going to make.
I
I'm
think
not going to make the obvious boys will be boys joke.
Oh my
no,
Lord!
it's like normal.
Yeah.
That's what we have to say is it's normal.
Yeah.
And we are sexual beings until we die, and we can choose to be sexually active, which is different than being a sexual being.
Right.
We can choose to be abstinent. That's fine. It's okay. When you're not harming anybody and you're pleasing yourself, it's okay.
Yeah. And it's healthy, right? And sexuality, being a sexual being, is a component of being a healthy person.
Well, hold on, because I actually think that's a pretty sort of transformative thought. If you've never heard that, and I actually kind of want
to say it again because
no.
you're so profound.
You're delightful, but no.
Okay.
I want to pull that back out a little bit when we talk about the idea of being, of having sex versus being a sexual being. Can you actually define out what it means to be a sexual being?
That is not an easy thing to do, because what it means to be a sexual being is a very individual thing.
Yeah.
It's very individual. So you might think about being a sexual being as something different than I think about it. So I don't think I can do that for you.
That's a good question, actually, Twila. And I was thinking as you were asking that I don't know. It's one of those things where you kind of feel like you know what it means, but it's hard to define.
But I think that's really important. Just the idea that as an expert, that you're able to sort of help us understand that it's not. It can't be boiled down to one small thing or one very specific thing, that there is a whole spectrum that you could fall in and still be considered a sexual being.
Right.
And I think for a lot of people, because we don't have the sexual education growing up, we just think it's one thing. We think it's a meeting of parts, and that's all sex is, and that's all that it comes down to.
That's so interesting, because when you talk about a meeting of parts, you're, of course, talking about genitals, male or female. And the largest sex organ in the body is
the brain.
No. That's
the
second.
Oh, doctor, can I the skin?
Yes.
Hey!
I got it.
He always did well in those classes.
It's always funny. It's like I get a little charge of just being right around Dr. LaValleur. It's been 20 years.
It's always good to be right with when you have a mentor that you're like, look, you taught me well. I learned that.
So yes, in fact, that's the skin is very much a very excellent way of treating several sexual dysfunctions, and we could talk about that a little bit later. But there's a process called sensate focus, which is using the skin in a mindful way to reconnect with our bodies and minds, how we are experiencing the world.
Can you talk a little bit about some of the changes that occur as people age? Because sexuality changes from when you're 10 years old to when you're 90 years old.
Absolutely.
And can you talk about some of the physical and emotional changes that happen?
Sure. Well, I might get off on a tangent, so you'll need to interrupt me.
That's all right.
All right.
So
that's Twila's job.
Let's talk about what happens to women in the perimenopause and menopausal time. We gradually begin to decrease our estrogen production, testosterone production, and progestin gradually over time. But then when menopause comes, and the definition of menopause is 1 year with no menstrual period, if we are not on estrogen therapy, the vagina gets very dry. It originally has 3 layers, but as time goes on, it goes down to 1 layer. And the vagina is an organ that truly, if you don't use it, you lose it. And so sex can become dry and uncomfortable and even painful. And there are things that can be done for that, multiple things that can be done. You can have estrogen therapy systemically or throughout the body. You can have it just in the vagina. And you can have non-estrogen therapies like moisturizers, lubricants for intercourse, etc. But that's probably the most common physical change that occurs around sexual function.
Yeah, because the vagina is a very estrogen-sensitive organ, and you go through menopause, and it gets, as you said, Dr. LaValleur, thinner, drier, and the caliber can actually decrease in size. Is that correct?
Absolutely. So as the layers of the vagina get thinner, the opening or the introitus gets smaller and smaller, especially in the absence of putting something in the vagina, whether it's a penis or a vibrator or fingers. The actual diameter of just the opening, not the upper part of the vagina, but just the opening. And that's what can become really, really painful.
So you're talking about you need some sort of actual mechanical dilation of the vaginal opening.
Right. And this is even more true with women who have never had a vaginal delivery because their vagina has never been stretched to allow a fetal head to come through. Right. And so the caliber of the introitus or the opening of the vagina is much narrower. And so those women probably need dilating more than women who've had a vaginal delivery.
So do all women, you talked about estrogen, basically estrogenizing the vagina, either by, you said systemic, which would be pills or patches or something that causes estrogen levels in the blood to be elevated over a menopausal state.
Throughout the body.
Versus a topical or localized estrogen in the vagina. Do all women, would you recommend all women have some sort of estrogen therapy to the vagina, whether it be in their blood or topical? Or can some women have fulfilling sexual lives and feel comfortable using other modalities?
I would never recommend that all women have estrogen in the vagina. There are some women who are afraid to be on estrogen. And for those women, if every time they put estrogen in the vagina or take a pill or put a patch on, if they are afraid of getting cancer, it's not worth it to them. And there are other things that can be done. Moisturizers, which have to be used a few times a week, or lubricants that can be used at the time of intercourse. So, no, all women should not be on estrogen. I do believe that all women should be knowledgeable about estrogen. Back in the early 90s, things began to change, ever since probably the 1930s. Estrogen has come into favor and gone out of favor on a somewhat regular basis. And estrogen is now back on the upswing again because after the 90s, millions of women stopped taking estrogen. After the Women's Health Initiative, and I was actually one of the investigators in that trial. But the trial was deeply flawed in that we gave estrogen to women who hadn't been on estrogen, starting them up to the age of 70. Yeah. And that's just something that was not done clinically. And now the data are becoming a little clearer that there is less risk for the adverse events if estrogen is started within 5 years of menopause. So now there's a little bit of upswing now on the use of estrogen.
So what you're saying is basically that, in reality, in clinical practice, it's younger menopausal women who are getting this, 50 to 55 to, late 50s, as opposed to some of the women in the study were being started much later than they would ever have been.
Decades later.
Yeah, and it's kind of apples and oranges in terms of possible risks.
Right, and let's lower that age a bit, Greg, because it's not just 50. While the average age of menopause is 51, there are women who start menopause at 40 or 41, or actually become more symptomatic, even in their middle 30s. They don't go a year without a menstrual cycle, but they become symptomatic sometimes in their middle 30s.
Right. So you had mentioned, and it's okay for us to talk about some specific resources. Where can women? Do you have any resources where women can go to that they can get more information on? You said estrogen. You had mentioned before the show the North American Menopause Society, for example.
To me, that is really an excellent source. Again, you just Google MAMS.org, and there is a section for patients. As a physician, if you're a North American Menopause Society member, there's also information for you. But there's an excellent, there are excellent recommendations about what to do about a dry vagina. And we haven't even talked about the most common sexual function issue or sexual dysfunction issue at menopause, and that is lack of desire or low libido. Now, and let me just say that the North American Menopause Society has a whole sheet, a whole list of things that women can do to fix a stalled sex life.
Yeah. So that's a great resource, and because that's exactly where I wanted to go to next. But you had mentioned that women can use moisturizers and certain lubricants. Are there any that you are kind of your go-to moisturizers? Like, if you see a patient, you say, well, just try this.
Yeah, we get that question quite a bit.
A lot. And so this is what I can say both about moisturizers and lubricants. It is very individual as to whether or not you like the product or not. Replens makes both a moisturizer and a lubricant. Some of them have kind of interesting names, like a lubricant called Astroglide. I always wondered where they got that, but I found out it was kind of discovered at NASA. But,
I was going to say.
Yep.
Yeah.
Those gloves are hard to get on in a space shuttle.
Another lubricant is Slippery Stuff, FemGlide. Other moisturizers are Moist again, KY Liquid Beads, and Silky, the word silk with a capital letter E after it. So really what you need to do is to try the various products and see which fits you best. If you have, for instance, a water-based lubricant and it gets kind of sticky and dry after a few minutes, just some water moisturizer will have it feel slippery again. So there are little things like that, again, individuals need to decide what is the best for them.
And I know that Astroglide, for example, and KY, you can get that at any grocery store.
Yeah, over the counter.
Can most of the things that you've mentioned be bought at regular places, or do they need to go to specialty stores?
Let's talk about a regular place. A regular place is a place.
That's a good response, Doctor. I love that.
No, that's
we got to change what you're saying without saying it. Is that we got to change the way we talk about this?
Exactly. Like there's a particularly, in my opinion, good store in Minneapolis called Smitten Kitten.
Yes, we have a relationship.
And their place is great. They offer every kind of lubricant and moisturizer that's known to God and woman, okay? And they also have helpful hints for you.
I got it. I've told the story. Can I just take 5 seconds to tell the story?
Go ahead. Eric has never told this story in 5 seconds. Okay?
Well, I'm just saying that this just reminds me of, I'm not going to use it, but one of the specialty stores in town, when we were doing live radio, there was a time when we were sponsored by that. And we had to go meet at one of these stores. And so I met with a salesperson. We said 10 o'clock at this particular store. And so, I park and I walk down the street. It's like, I feel like the stereotypical guy with the the collar turned up, and, kind of looking, nervously.
Exactly.
I go in there and I see the salesperson at the desk, and there was at least 10 or 15 feet that I had to navigate with toys on either side. But she just looked. We just locked eyes, didn't look one way or the other. I just went over there. And then began a session of education about lubrication. The same person at the desk was like, "Come on over here," and there was like 300 different lubricants.
Yeah,
I mean, there is a world, Twila.
Yeah,
world of lubrication out there that.
Well, I'm a huge advocate for this. This is probably one of my favorite things that we wind up talking about, because I think most lay people don't have an education, and they don't have enough of an education and a comfort level to go seek this out.
But let me just interrupt you I'm going to mansplain here.
And actually,
I'm going to
woman slam you.
Because I'm pointing at her. It's amazing how comfortable they make you feel. And I'd like to encourage the people who are nervous about going to the stores, go in there.
Yeah,
they will make you.
Well, I think one of the biggest things to Dr. LaValleur, you hit it. You said it very specifically when you said, we're going to get away from referring to something as a regular store.
I love that.
Because yes, in the standard big box stores or big box drug stores that we go into all the time, yes, these products are available and they're out in the open. But the employees of the store don't necessarily know what the products do or how they function. They can't answer questions for you. And I think most of us of a certain age, and I fall well within that. I'm 43. We grew up thinking
you're just a baby.
I know. I got the you're a baby wave, which I love because that never happens in my life anymore. We very much have a very specific set of information in our mind when it comes to the type of stores we're thinking of, that they were the stores that you snuck into as a gag as a kid, or they were the place where you went to get like the bachelorette stuff for the bachelorette party that was, let's go find penises on necklaces. It was, that kind of thing. Oh, completely. Beyond. And then, so there's
Christian woman like you.
We know in the last 15 to 20 years that there's been a foundational shift in the types of stores that are now available and the types of information and education that are available. Yeah. And we are very lucky where we live that we have a resource like Smitten Kitten and some of the other stores in our area where they're not just employees and they're not just sales clerks. They're actually educated. They're
resources, right?
Yeah, they're actual, health professionals in many aspects. And you can come in and say, I'm looking for this, or I don't know where to start, but I have this issue, or I have this information I'm trying to get. And they won't just say, go in the back to this section. They will walk you through. They will help answer questions. They also have amazing websites, because I understand that even with all the information, you might not be comfortable the first go-round putting yourself in this new space. This is a very vulnerable space. Yeah. So to be able to go to something like Smitten Kitten's website and not only look up a product, but look up instructional videos and Q&As and frequently asked questions and get real information that you can be comfortable with in order to proceed is a very powerful tool. And it may be like the one true catalyst that will get you from being afraid to try to actually moving forward into action.
Yeah.
Support for the GynoCast is provided by OBGYN West. OBGYN West provides the highest quality care from compassionate providers, including women's health issues from general sexual health to pregnancy care, childbirth, menopause, and beyond. Whether it's your teen's first annual exam, a new baby's on the way, or you're facing the special challenges of middle age, OBGYN West provides a wide array of services. Their doctors and PAs are trained in virtually every type of OBGYN service and procedure. OBGYN West provides exceptional care for women.
You said something a little bit earlier, and I want to address that. You talk about people who, both men and women, who are uncomfortable, as Greg was when... see, I do that all the time.
That's all right. I'm just going to pop it in the notes. It's
okay. That Erica mentioned about how uncomfortable he was about walking into the store. Yeah. Well, that is true with many physicians.
Yes.
Many physicians do not bring up sexual function
That's right.
issues with their patients. And there's a whole list of things that says why they don't. They're afraid they'll embarrass the patient. I can tell you that, to my knowledge, no patient ever in the decades that I was in practice ever was upset because I brought up the issue. In fact, I have a story, but it takes a little bit longer. I had a resident who was not trained at the university, and she went in and did an exam on the patient, and I was following, and I looked down, and all the questions had been answered except sexual function.
Mm-hmm.
And I said, this one is blank. I said, did she not have any issues? And the resident said, well, I didn't ask her. I said, why not? She said, well, she's 74.
Mm-hmm.
Was that an opportunity or what?
Yeah.
Wow.
So I don't
lost.
think she ever didn't ask that question again.
That's right.
But it's so important to our quality of life. Earlier you mentioned that that case, and we have data, we have studies that show that if women and men have satisfying sexual lives, they live longer.
Yep.
Mm-hmm. Mm-hmm.
So it's important to the quality of life. It's important to life overall.
I would imagine, Dr. LaValleur, not only do they live longer, but I would imagine just life satisfaction, quality
Happier.
of life would be.
Mm-hmm.
And intimacy is, and we're pack animals, and we're supposed to interact with each other.
Well,
Right.
but think about that as the whole. Think about there's actual studies that show how important that is. And for as strangely hypersexualized as our culture is, and all of the things that we consume in
Yes.
terms of entertainment and music and movies and television, this is still the one area that we avoid like the plague. We don't talk to our
We have talked about
personal.
we don't talk about it personally. We don't talk about it with our girlfriends. We don't talk about it. I have teenagers. We don't talk about it with our kids nearly enough. And I always point out that the most sort of delightfully specific thing that has come out of the work I do with Eric is that many people in my life now think that I am the go-to resource, that they can and if nothing else, they can comfortably talk to me about sex, even if they're not looking for information. So I have now become the lady that gets the hushed, I listen to your show
in the closet, so
By
my
the
kids.
way-
yeah,
can
like
hear.
I listen to your show, or I heard this show you talked about this thing, and I'm like, well, good. Hopefully it was helpful to you. If you felt like the need to tell me, then it must have been helpful to you. And at first I think I sort of giggled about that, and then I kind of, as time has gone on, I've just been like, I really appreciate that. If this does nothing else but makes it easier for one person in my life to think about these things or to seek something out for themselves, then that's a victory. We've actually really done something good.
Yeah.
Well, I was going to say that, Dr. LaValleur, I'd be interested in your thoughts on this, but in my clinical, I've been in practice now, it's hard to believe, almost 20 years, oh my goodness. But the amount of, sexuality can be such a positive force in our lives, but the amount of pain and an injury that you see in our patients that are coming in, how sexuality and sex in general has not been a positive force in their life. It's been a damaging element of their life that has really continued with them. And what percentage of I guess your patients do you think have had negative sort of experiences in terms of sexual experience or sexual exposure?
So I'm not certain if you're talking about unwanted sexual advances or actually rape, because rape
That's a good
is
point,
not
yeah.
a sexual thing.
Right.
It is a dominant, violent control issue.
Mm-hmm.
And I understand that for women who have been placed in that position, and some men as well, I have a hard time disconnecting the sex part with the violence and dominance part.
Yep.
But we have, again, pretty good data that show that up to a quarter of women have been exposed to sexual violence. And the most important thing, in my opinion, is that women and men who have been victims of sexual violence get treated for the deep psychological and emotional issues. And they're treated by someone who understands, someone who has a great deal of experience in dealing with rape and sexual violence. So I think what's important is to find out somebody who has an experience or expertise in that. That is not my area of expertise, and I'm clear about that. But I ask women if that has been the case.
Right.
And if it has, get them to someone with the appropriate training. In my years, I've had so many women say, well, I've never told this to anybody.
Yep.
And so they felt safe in talking to me because we had an established relationship generally.
Yep.
And then I'm able to get them the therapy that they need.
And I think this kind of just emphasizes again the importance of having the discussion that we're having today, because in the past, we didn't talk. Sex was not discussed.
Right.
Whether you talk about the positive aspects or the possibly negative, it was not discussed. And so the importance, as we're talking about right now, is actually talking about the subject. And so, Dr. LaValleur, and I wanted to say as well is that you are the only physician, I think, in 4 states that is.
Yes, 5 actually: Minnesota, North Dakota, South Dakota, Iowa, and Wisconsin. I'm the only physician who is nationally certified by the American Association of Sexuality Educators, Counselors, and Therapists. So there's hopefully in one of the journals this coming month, there will be an article that I wrote about ASECT and being trained. And physicians can get trained in doing sexual health. It requires investment of time and money, like everything. But when I retired a few years ago, I decided to go back to school so I could learn more about men's sexual health, because as a gynecologist, I wanted to know more about that. So 2 years and an exam later, I am now certified to see both men and women in the sexual health arena.
Wonderful. Now, you had alluded to this just a little bit back, which is the main complaint that many perimenopausal or menopausal women have, which is issues with desire. Can you talk a bit about that?
Oh, yes. Men and women are different. We have different sexual function cycles. And decades ago, Masters and Johnson described the sexual cycle, but it really didn't fit for women. So
yeah, it was totally male-based, wasn't it?
Yes.
Linear.
Yeah. Linear, very linear. We now have a more circular model developed by Rosemary Basson. And we know that women who have no desire may still be able to have a sexual encounter. They just enter the cycle at a different phase. They're motivated to please their sexual partner. They love their sexual partner. So with a little foreplay and a little appropriate sexual setting, they can become aroused, go on, and have an orgasm.
Can you talk about the phases when you get a chance?
Sure.
Sure. Because I think the phases are somewhat similar between males and females. It's just, is that right, that one is more linear and the other is more circular?
Right. And the phases are arousal, and so that's in women where the vagina becomes lubricated, and in men they get an erection, and then there's a plateau where you kind of stay at that phase for a while. Then you have orgasm, and we could talk for hours about orgasm,
a
but
subject
we'll go
that never
on.
gets boring for some reason.
No, it isn't.
Nope.
And after orgasm, there's resolution. And for women, many, but not all, can have multiple orgasms. And for men, depending on the age and the situation It can be a few minutes when young men are in their teens and 20s to days before they can have another erection, orgasm, and resolution. One thing that we really haven't even talked about in this aging is the effect that many medications have on any of the phases of the sexual response cycle. Mm-hmm. Examples such as, one of the most common conditions is hypertension. And there's two medications that we give, diuretics and beta blockers, which have horrible effects on sexual expression and the sexual response cycle. And unfortunately, not all physicians say, here's a prescription for whatever. You might have a sexual function side effect, and if you do, let me know. They don't do that because then they're afraid that the patient will not take the medication. Right. But it's important to say it's not 100% that you will, but you might. And so if you do, then we will try to find something else. I saw a man in his 70s when I was a medical student who I was doing an exam, an annual exam, and men don't often do that, come in for their annuals in their 70s, but I naturally asked, even though it wasn't on the form, have you or your partner have any difficulties with sexual function? And he kind of looked down and said, yeah, well, I haven't been able to get it up for a couple years. And I said, really, did anything change then? Not that I know of. So I looked at his record, and he had been prescribed a beta blocker. And he had thought that it was because he was 70 that he couldn't get it up anymore. But it wasn't his age. It was the beta blocker. But no one had asked him the question.
Nobody's looking. Nobody was paying attention.
Nobody is looking.
Wow.
So a lot of medications have a negative impact on sexual function. Anything that acts on the brain, antidepressants, anxiolytics, medications for anxiety, for instance, multiple medications that use to treat hypertension, to treat diabetes. Those are heart disease. Those are all very, very common as we age.
Well, depression, anxiety, all those.
Well, I said these are all the wheelhouse. Everybody I know is on some version of some type of medication.
Right. And it may, not will, but it may affect their sexual function. And it's up to the patient to bring it up, but the patient is reluctant to bring it up because they're embarrassed about it,
right?
Or they think they will embarrass their doctor. The doctor doesn't bring it up because they're afraid they're going to embarrass their patient, or they don't know what to do if there is a sexual dysfunction. And they don't really need to know what to do except to get them to somebody that can help them.
Right.
Yeah.
Right. So when you're trying to figure out, we were talking about, I guess the best word that people know about is libido or desire. One of the things you're looking at is not only age, your other medical problems, medications are on, for example.
Yes, there are. And in the past couple of years, there have been a couple of medications that have been approved by the FDA, and there are kind of more in the works. And the medical term for low libido is hypoactive sexual desire disorder. And in order for that to be a disorder, it has to bother the patient.
Yeah, it has to be a problem.
It has to be a problem. So if somebody has no libido, but it's not a problem for them, it's not a problem.
Right.
And we don't need to do anything with that. The problem with the medications are many. One, insurance doesn't pay. Pays for, all of the erectile dysfunction drugs, but doesn't pay for this. On the other hand, it's $800 a month. Minimally.
Is this? Can I say? Is it the medication that's very hard to say? Is it like flibanserin or something like that?
Flibanserin.
You were close.
Well, I'm just pulling this from the deep dark room, but flabanserin, who comes up with that? It sounds like something that would bounce really high.
That's a marketing tool. If you notice, most of the new drugs have an X, a Y, or a Z in them, and that's because that is attention grabbing. Okay, flabanserin doesn't, but I don't know.
Sure, I did actually remember it. I didn't pronounce it right, but I remembered it.
The issue is even as little as 2 alcoholic drinks within a few hours can cause severe hypotension, a lowering of the blood pressure, and can cause fainting. And so there's now a black box warning. In addition, to prescribe it, physicians have to take a course on how to prescribe flabanserin. So,
does it work?
In some women, yes. Nothing works 100% of the time,
right.
And that's because low libido is multifactorial. Mm-hmm. It's not just the medication. It's not just the aging. It is the relationship with the partner.
Right.
And for women, it is, okay, I need to get at least 7 hours of sleep tonight because I've got X to do in the morning. And the last thing I want to have is sex right now. Okay. So I got a lot of referrals when I was in practice at the U for low libido. And I remember in particular a patient who was referred. And I asked her the usual questions, and everything was fine. It's fine. Everything's fine. And so
why'd she come in? Everything's fine.
So I said, well, tell me what happens in a usual encounter. Be specific. Well, it starts when I get home. If his pickup is in the driveway, I get nauseated.
Wow.
That's a bad sign.
Wow.
So I wanted to say, well, perhaps he should get a different pickup, but I resisted that.
Being a nuanced and complex thinker, you move beyond that response.
Exactly. But I can say that was one of the first things that came into my mind. But I took her absolutely seriously. And she didn't like her husband. I had women who had been married for 50 years to men who were emotionally abusive.
Yeah.
And they stayed in those marriages. You cannot expect to want to have sex with somebody who's emotionally abusive. And so there's all of these things that play a role in libido. It's the 3-year-old crying in the next bedroom or getting up in the middle of the night to have to breastfeed a baby. All of those
unpaid
things.
Bills, dishes in the sink,
Yeah.
And men can help me out here, but I'm just going to ask both of you women, but I think men can get an erection with bombs falling and thunderstorms coming, but it's different from many women.
For a lot of women, it's very much a mental game.
Men don't care about the dishes in the sink.
Right. We have we had someone a long time ago on our radio show explain that it was more men use sex to create emotional connection and create physical intimacy, and women need the intimacy before they can have the physical connection.
Whoever that was dead on.
So why, Dr. LaValleur, why did the great designer of the universe, whoever you decide she is, create this discrepancy? Like, why can women have multiple orgasms and most men only have one?
It's the least.
You have
it's
30
the
seconds.
least we can do.
You have 30 seconds.
It's the least we deserve because we pass watermelons through our vaginas and then raise them. It's the very least.
All right, I'm not going to argue with that.
Yeah.
All right, that's a good response, Twila, actually. Dr. LaValleur, do you have a response to that?
It's probably better than what I can do. Except I hope that's a really small watermelon.
Yeah. Indeed.
And it's sort of an interesting thing. Do you ever sit up at 2 o'clock in the morning kind of wondering why these discrepancies happen?
No.
Okay, because you're getting therapeutic sleep.
Not always. I'm menopausal, But anyway, the one thing that I will say about the Creator, they gave women a clitoris. It has one function.
Yeah.
Sexual pleasure.
Yeah, so you cannot argue that pleasure is not normal. Pleasure is normal.
Pleasure is normal. And, we hardly ever talk about sexual pleasure or having fun with sex. And a lot of times we kind of laugh or giggle when we're talking about sexual things.
Yeah.
Sometimes that can be to relieve whatever things we
discomfort
have
you
going
have,
on in
right.
our head.
Mm-hmm. Absolutely.
But sex should be fun.
Yeah.
That is, sexual encounters should be fun.
Yeah.
Even thinking about sex could be fun.
June, I got to tell you that Twila, don't use the word pleasure on Twila. She likes it pleasure.
No, I don't. Don't listen
pleasure.
to him. Don't listen to him.
Okay.
It's all about sexual pleasure.
Don't. He has this thing about accents, and he knows that drives me bananas. He tries to
We've
toss them in
we've worked
whenever he
together
can.
for a while.
Yeah,
We
he
can
knows.
have a discussion about bananas, but we won't go there.
But
But this is important. Sex should be fun. Thinking
Yeah.
about sex should be
Well,
fun.
you know
it
what?
should
I
be
think that's-
pleasurable.
Well, no, I think that's a really important piece of this because I don't even think we allow ourselves to think about sex without thinking something's wrong with us for not thinking about it only within that context of when it's going to happen. If you're sitting around in the middle of the day thinking about sex because you're thinking about it, we've kind of trained ourselves and has this overall sort of societal blanket that's like, what's wrong with you?
Mm-hmm.
That's not, we don't do that. Good girls don't do that. I mean, I probably make the same joke once a week, which is if I died tomorrow and you checked my browser history based on the types of shows we do, you would think that I spend an inordinate amount of time looking up crazy things.
Like what?
But it's perfectly normal. Huh?
Like what?
Well, like all the years,
Orgasm.
like all the years that we did the show with you, and I populate the grid with like alternative stories. So I have like
I just want to
my browser
I just
window
want
is
you to
full
say
of
it
things
out
like,
loud, Twila.
oh, you know, my browser history is full of like orgasm stories, vibrator stories, weird new sex toys that are on the market, like things made by women, sex studies. Remember we have I still somewhere in my browser history have the study about penis size, the worldwide penis size study.
Let's talk about sex toys.
Let's do that.
Listen, it's
Oh,
my
wait,
second favorite topic.
June, I want to get to that, but I also want to let's finish the libido thing, or
Okay.
you'll probably. But we talked about flabanserin, we talked about estrogen.
Mm-hmm.
The thing that most people have heard about and there's a lot of dispute about is testosterone. What are your thoughts about testosterone supplementation in terms of helping with
Yes.
libido, achieving pleasure?
Yes. Again, libido is multifactorial.
Mm-hmm.
I have had patients who have had very low testosterone levels and have
Great
excellent
libidos,
libido.
yep.
And women who have high testosterone levels and have no libido.
Yeah.
So it's just one of the puzzle pieces.
Do you prescribe it? Is it a tool
I
in your
certainly
chest?
have.
Okay.
It is a tool in my chest for some women. However, it has to be used. It is not FDA approved.
Mm-hmm.
And so it's critical that patients know that
Mm-hmm.
when they get it and know what the side effects are and what the complications can be. We did a study at the U using the testosterone patch. I can tell you it was the easiest study I ever recruited for. No, I take it back. It was the second. We did a follow-up study so that people who had been on it could stay on it. That was almost 100%. So that was an open label study. And what they found was actually the same results as was obtained by flabanserin.
Oh, really?
It improved their sexual contacts that were satisfying to the patients by approximately 1 a month. So people said, what's 1 a month? What's 1 a month? Well, if you're
having
having
zero.
1 a month
Right.
and you have 1 and now another one, that's twice.
100% increase.
And if you go from 2 to 3, that's better. But in their wisdom, it didn't show enough power to manage the issue. So it has to be given in very low doses. I have seen a woman who had massive levels of testosterone in her blood. She was a singer. And unfortunately,
Oh, boy. That's not good.
that does not change. Changing of the timbre of the voice is one of the side effects, and it changed her voice forever. Side effects can be losing hair where you don't want it,
enlarged clitoris.
clitoromegaly or an enlarged clitoris, but for some women, that's okay.
Yeah.
And there's really been no long-term studies to show that testosterone has been harmful to the heart. They look at some biomarkers like cholesterol levels, etc., and in proper doses so that your level remains at a premenopausal level. This is actually for postmenopausal women. It's not been shown to have a significant effect. You would never, ever give it to women who could get pregnant because it could masculinize a female fetus.
Wow.
So, I guess what I want to kind of bring this back around a little bit, which sounds like to me that, we talked about vaginal dryness, and there's some ways of dealing with that. And the other main subject that people are concerned about is libido. And it sounds like when you approach a patient, it has to be kind of a global or big picture, systemic kind of approach. You're looking at their life, their relationships, the other stressors, medications, their overall health, and that there's a multifactorial chest of tools of toolkit that you have to help people with this.
Absolutely.
And that, but can you? I guess the question I have is that if you're 70 or you're 80 or you're getting older, is it reasonable to expect that you can have a satisfying sexual relationship with your partner if you wish to be with the tools that are available?
Yes.
All right. Thanks for joining us, Dr. LaValleur.
I like a good definitive answer.
Yeah, that's right.
I love it.
All right. So, Dr. LaValleur, I want to thank you so much for joining us on the GynoCast. We've been speaking to Dr. June LaValleur from Minnesota Personalized Medicine. Where can listeners go to get more information on Dr. LaValleur?
Well, everything we talked about today will be up on the syllabus, and you can get that at our website, matriarchdm.com. As always, the show page is there, and you can listen to the episode, listen to previous episodes, and get any and all information about our guests and resources that she shared with us today. You can also email the show now at hello@matriarchdm.com. You can email the show and let us know all of your thoughts. And we have a Facebook page.
Yes.
It's a really lovely way to connect. Go to Facebook, and you can sign up for our private page. It is the GynoCast. So you have to search it, and you have to request to be a member because we talk about sensitive issues and sensitive topics, and we want to make sure that we're providing a safe place to do that.
That's right.
And you do your due diligence. We'll check you out, and we'll let you in, and we continue discussions. You can propose things that you want us to talk about.
That's right.
We talk about lots of things on that page. It is a lively, spirited, but super lovely and respectful group.
And there's almost 2,000 people, and it has a life of its own. It's
yes,
kind of exciting.
It really does.
Talk amongst each other.
It outruns us all the time. Sometimes I'm away for a few days, and I come back and go, I'm sorry, I missed the party. I didn't mean to. But it's a lovely space, and we want to make sure that you're having every available resource. And as always, we do this because you support us, and we appreciate it.
That's right.
Thank you.
Thank you, Dr. LaValleur. Thank you, Twila Dang. Thank you for listening, and we will hear you. We'll be back soon.
I would just like to say thanks to both of you for bringing this vitally important topic to the public. Thank you very much.
Well, thank you for coming today.
You're welcome.